All right, well, welcome back to Ultrasound Grand Rounds this week. I'm pretty excited to be here as always. You know, this fall has flown by. I can't believe how fast it's gone. As we're recording this, we are now at the end of October. It's hard to believe that another month has come and gone. You know, the leaves have peaked on the trees, and I guess just for a little bit of fun for those who may be joining us from other different audiences online, here's a couple pictures that we did. We did a family hike a week or so ago, just here in Northeast Ohio. And it was just absolutely gorgeous looking out over the valley into the Lake Erie on the left-hand image, and then just kind of looking at the sun coming through the trees on the right-hand image. And it's a fun time of year, but it's just been busy, with a lot of things going on. But we're excited to be back. We're excited to be, here talking about more ultrasound. Last week we had a little bit of a fall break. My family and I went and did some camping, but we're back in the swing of things. We're going to hit up cardiac ultrasound today. We may hit that another time or two over the course of the fall, but then again, next week, we're going to talk about some more ultrasound, and then we'll go back to our every other week cycle, kind of hitting us up for middle of November before we kind of get into the December winter season. So anyway, that's just kind of a look at the overall kind of plan for what's going on. But today, let's dive in a little bit to some cardiac ultrasound, right? We're going to talk about the 5 E's and the 5 C's. So the last couple times we met together, we talked about the FAST exam. And what we're trying to do is kind of a back to the basics type series where we get back to looking at more of a and I kind of want to say a little bit of a beginner level ultrasound, but also just kind of a entry level, beginner level, basic ultrasound. Because we get deep into some of the really deep weeds, as we go throughout some of these lectures, and they can be kind of hard to process if you don't have the basics. And so what I'd like to do this fall with these previous lectures, this lecture, and kind of the ones coming up, is just look at some of the basics that can help us kind of build that foundation, so then we can go back and watch the other videos or see some other more advanced things coming up, as we go through these other topics. So that's what we're going to do today. We're going to talk about cardiac ultrasound, right? And so as we kind of get going, obviously no disclosures to make since this is a CME event for those who are watching it live. If you are watching on the YouTube, well, I'm sorry, we can't do CME on the YouTube. You should be here live watching it with us. But anyway, you can just join in and learn stuff as well, nonetheless, right? So our objectives today are going to be talk a little bit about, why we want to do bedside ultrasound. We'll spend a few slides talking about that, and then review some cases as a way of illustrating some very important points that we need to hit in basic cardiac ultrasound, right? And hopefully these cases will then be show some pathologies that are relevant to emergency medicine and to critical care as we move kind of throughout the course of this lecture, right? So that's kind of the general overarching idea of what we're going to try to accomplish today. So I think as we dive into this, let's start with kind of like, why should we do this cardiac ultrasound? And maybe back up and ask the question, what is point of care ultrasound or POCUS when we evaluate the heart? And I think some of it's we always assume, we kind of gloss over and just say, yeah, it's just doing ultrasound at the bedside of the heart, and that's not wrong. But if you want to get a little bit more of a definitional understanding around it, the American College of Cardiology has put out some documentation about cardiac POCUS, and they define it this way. They said cardiovascular POCUS refers to a limited imaging protocol employed to detect or characterize a subscribed list of readily apparent pathological findings to facilitate serial assessment of specific anatomic or physiologic parameters. I think I missed an or in there, or to facilitate serial assessment of specific anatomic or physiologic parameters. And so it's just basically a bunch of fancy language to say we have a heart, right? And we find that there's utility in looking at this heart, right? We can look at this heart and we can use it to understand either what pathologies are happening or to monitor the patient's progress as they go throughout the course of their hospitalization. Because we know that, patients' status is not a stagnant thing. It's not something that doesn't change, or it's not immutable. It's always dynamic, right? Be changes that happen, and so we can go back and reassess kind of what's going on. And so the ultrasound is a really helpful tool as we start trying to get a better understanding of what's going on with these patients. And so cardiac ultrasound is something that's recognized not only by the American College of Emergency Physicians, right? It's not only recognized by American Institute of Ultrasound Medicine, but it's recognized by the American College of Cardiology and the American Society of Echocardiography. And so where we used to have maybe some pushback of, this should be left in the realm of comprehensive echo labs, I think there's a growing consensus amongst all providers that there is a utility and there's a role of taking the ultrasound to the bedside in these patients with potential cardiac issues or hemodynamic instability or whatever, and using this to assess for what's going on with these patients to help us in our decision-making and management for these patients, right? So that's kind of the what is cardiac POCUS. Now, let's try to think about it conceptually, and then we'll dive into some specifics here. And when I think about the heart, right, when I think about the cardiovascular system, I like to think about it in the form of something that I kind of gravitate towards or I understand. So in a former day, and I don't have a picture in this particular lecture, I should have put it in, but in a former day, when I was in college, I worked at the fire department for the town that my college was in. It was a local volunteer fire department. It's probably three and a half of the best years, of my life, and that I was able to do something fun with a whole bunch of great people. And who doesn't like riding big trucks and squirting water on fires, right? It was a great experience to have, very formative for me personally. But one of the things that I learned, one of the things that I kind of picked up while I was doing this is the concept of, the water and how you get water from one place to another, right? And so we think about things in the form of pump, tank, and pipes, right? So you have the reservoir on the engine, you have the pump on the engine, and you have all the hoses that you stretch to put the water in the fire, right? And you can think about that as a system that gets one thing to where it needs to be, right? And so I like to think about things in the context of pump, tank, pipes, right? And so this is I asked the AI engine to create a picture of a pump, with two tanks and some pipes connecting them and recirculating valves. And this is basically a mechanical, shall we say, conception of what the cardiovascular system is, right? Essentially, we have a reservoir on the arterial side. We have a reservoir on the venous side. There is a connection there, right? The recirculators through the capillary system. And there's a pump in the middle of that pressurizes, that pushes things through. So it's constantly in this closed system, hopefully closed. Otherwise, we got to talk to our trauma folks, right? But this closed system that helps us understand kind of this dynamics of what can go on, right? And so as we think about this particular scenario, right? Just back up. We're not talking about medicine. We're talking about this pump, right? This pump in the system. Hopefully, we're going to see just this constant circulation. We'll see a pressure. If there's a valve in there, we'll see a pressure valve that shows kind of how much pressure is being developed by this system. And it's going to run. We could put some, turbine in the middle of the, the outlet valve, and it could run something like you can create energy off of this system if we put like some flow turbine, right? And it's a very complex system, right? And you can start imagining, if your goal is to create some form of mechanical energy through this system, right? You need to keep all the components of the system working. And when one of them fails, the system fails, right? Now, when one of them fails, you're going to start noticing patterns of what's going to happen to the rest of the system as that system or that part fails, right? And this is kind of where we start drawing those corollaries back into medicine, right? We can begin to start understanding that the cardiovascular system is much like this mechanical, pump, reservoir, circulatory system that drives something. And there's many, many different aspects that can become pathologic, that can fail, that cannot work right, causing the whole system to then be less efficient than it ought to be, right? And we see these things in the form of signs and symptoms on our patients. And so as we start trying to diagnose this, we need to start analyzing is there a problem with the pump? Is there a problem with the reservoir? Is there a problem with the pipes? Is there a problem with the liquid in the pipes? As we start really understanding kind of what's going on with the patient. So bringing this back from the mechanical realm, now let's come back into the physical realm, right? The clinical realm. And we start thinking about as we assess this whole person, right? This person in front of us, there's going to be some form of signs, symptoms, things that's going to bring them to our attention medically, right? There's going to be some hemodynamic problems, right? And we're going to want to start analyzing and understanding and assessing what's going on. And traditionally, this is done through the form of the history and the exam. In fact, they said 85% of all of diagnoses are made based on the history and exam alone. Seems plausible, although somewhat skeptical, because I've also heard the statistic that 80% of all statistics are made up. including that one. So, be that as it may, the history and the exam are very important parts of kind of analyzing this patient. And then we start adding other things to our analysis, like EKGs and biomarkers and vital signs and all this type of stuff. And so we can start developing this picture of what's going on. And again, let's back up, make another analogy. Think about when you take your car into the shop, right? You take it to the mechanic and say, hey, look, in fact, I had my truck in the shop the other day. I said, here's the problems that are going wrong, right? Here's the things that I've noticed. And the mechanic's going to, talk to you. They're going to hear the story. They're going to maybe get in and drive the car around and find out kind of, okay, I see what you're talking about. They're going to check some fluids. They're going to check the engine lights and all sorts of these assessments to help understand what's going on with this particular patient, right? And so this is kind of what we're doing clinically with our patient. However, all that's good, but it only tells us what we can see, what we can hear, what we can touch, hopefully not taste, right? But what we can analyze with our senses, and then some other things that we can maybe surmise based on, biomarkers. Hey, this level's elevated, this level's decreased, so what are the things that can do that? We paint a picture, put it all together, and I think it probably lends us here, right? So that's all well and good, but we practice in the 21st century, and we've developed this whole idea of, developed an ability to be able to peer in deeper than the skin, right, with some imaging. And so other things that we can bring to the table with this patient who's, not doing so well is some form of imaging, right? And that can be done in the form of chest x-ray, which, I describe to our residents is basically a shadowgram, right? When you kind of put your hands together and make the shadow of a dog on the sidewalk and say, woof, woof, it's barking, right? This is what a chest x-ray does, right? It gives us a shadowgram. And there's some validity to it. There's some reasons why we can do it, but essentially it's it's looking at different, degrees of shadows on a film, right? But then if you want to get a little bit further, we can do CT or MRI, right? We can do comprehensive echo. All these are great ways to peel the skin back and start analyzing what's going on. But what I want us to really do and focus in on today, because all these require time, they require travel outside of, our clinical operational areas. They require other people to be involved and, have expertise. I want something that I can use at the bedside to adjunct with my history, with my exam, the other markers that I'm getting, that I can then look and see what's going on with my pump, what's going on with my tank, what's going on with my pipes, as I'm trying to analyze this patient who's unstable in front of me. And this is where point of care ultrasound comes in. So when we talk about the why, right, and we talk about the what, this is kind of what undergirds all of it and how it helps kind of go along with our whole assessment of the patient as we're looking at what's going on, right? And so with that being said, we're going to spend the rest of our time today talking about cardiac ultrasound or cardiac POCUS, right? But it's a broad topic. As I've lectured about this, as I've done this clinically myself, as I've kind of observed our other faculty around here, it's one of the biggest studies that we do. In fact, I've monitored the trends of our studies over time, and cardiac ultrasound has just gone up and up and up, right? As people have gotten more and more comfortable with doing it, with analyzing it, with figuring out what's going on. So it is very ubiquitous part of our practice here. But also, as I've tried to give summary lectures in the past, I've struggled to put kind of like here's why you do it, here's what it shows, and here's what you're going to do about it, because there's so many ways to get into a cardiac ultrasound. There's so many different things that can happen when you do the cardiac ultrasound, and there's so many different outcomes that you can use the ultrasound to then drive, right? And so as we start doing this, we need to develop a mental framework, right? So a way we can start analyzing this information, right? Ask ourselves a series of questions that we can use the ultrasound to help answer that really can walk us through this in a systematic way, right? And so point of care ultrasound works best when we say, hey, I have a specific question that I want to ask. I'm going to get a specific answer with my ultrasound and see how I can use this to then drive the changes that I want to see in patient management or patient assessment, right? And so that's what we're going to talk about today, that framework for how we can think about cardiac ultrasound, right? And then the rest should hopefully just kind of fall into place as we start seeing our patients. So to do that, I want to turn us to a very, very instrumental paper. In fact, I think it's one of the landmark papers, in my opinion, that has been published on cardiac ultrasound at the bedside by mostly emergency physicians, but you can apply this to other POCUS users as well. And that is this article, right? The 5 E's of emergency physician performed focused cardiac ultrasound, a protocol for rapid identification, effusion, effusion, ejection, equality, entrance, and exit. And this is published by the folks at Yale. So there's a lot of folks on the paper, but it was published in Academic Emergency Medicine 2015. I think this is probably one of the best articles that summarizes cardiac ultrasound. I'd highly recommend you go look it up. I'll leave this on the screen here while I'm talking so you can kind of jot down the title. But look this one up. This is going to provide a lot of details, a lot more details than we're going to go into today, but it has some really good images, really good charts to summarize cardiac ultrasound. But it gives us a nice framework that as we assess this patient, as we go to the bedside and say, okay, I need 5 yes or no questions, right? Or 5 easily answered questions that I can then answer in a protocol form. And then the answer there kind of drives what we're going to do as we move forward in this patient. And so the 5 E's, they're in the title, but here's the chart that we're going to come to. I'll put it up back at the end, but this is the main chart in the paper. Basically, the 5 E's are effusion. Is there an effusion? Kind of how do we describe that? What's going on with that effusion? What effects does that effusion have, right? We'll talk about that in a little bit. Number 2, ejection. What is the ejection fraction? How well does this, this left heart function, right? What does, varying degrees of ejection fraction mean? How do we assess that, right? Number 3, equality between the left ventricle and the right ventricle. What does it mean when what is normal, right? And then when it's not normal, when one's bigger than the other, the right ventricle is bigger than the left, what does that mean, right? And how do we interpret that? So that's equality. Exit is basically the aortic root. So what's it supposed to be? What happens if it's big? And then entrance is what's the IVC. So how do you get blood into the heart? Because, at the end of the day, the heart's a pump, right? It doesn't sit there, shouldn't be stagnant. It should be flowing through. And so it's got to come out, or the exit, the aorta. It's got to come in the entrance and the IVC. And so what does it mean when it's big, but when it's small? What are we looking for? Things like that. And so that's kind of the 5 major questions that we want to ask, and beyond that, right? If you want to go to more advanced levels of echocardiography, you can get deeper into, valves and regional wall motion abnormality. You can do pressure gradients and all sorts of great things. If you want to learn more about that, we got a bunch of great videos on the YouTube channel. Head on over there, check it out. There's a cardiac ultrasound playlist where you can get those. But these are the 5 basic questions we want to ask of all of our cardiac ultrasounds, and everything else beyond that is gravy, right? So with that being said, we're going to dive into each of these 5 in order with some cases, right? I'm going to show how this works in real life and kind of how we start processing through that. So case number 1, right? This is a category 2 trauma. Patient came in, shot to the chest. One of the major indications for cardiac ultrasound, particularly in trauma, is penetrating trauma to or through the chest, right? And so there's a lot of vital structures in the chest, right, around the mediastinum, the heart, the lungs, great vessels, a whole bunch of stuff like that. And so when you have a penetrating wound to those, you have to be very suspicious that there's going to be an injury, particularly to the heart, right? And so cardiac ultrasound is highly indicated when you have an injury fitting that that classification, right? So this patient was shot to the chest, came in as a category 2 trauma. We, as the ultrasound team, were assessing them in parallel with the ED and the trauma team, right? And so we basically started with, is there, a lung sliding? Is there pneumothorax? Well, on the left side, there's normal lung sliding. On the right side, there's normal lung sliding. Okay, good. No pneumothorax. Obviously, we can dig deeper into that. We've got lectures on that. Go watch those on the YouTube channel. But let's turn our attention to the heart, right? And the first thing that we see here is we got a subcostal view, right? A 4-chamber view, and there is some fluid within the pericardial sac, right? So you see the 4 chambers, you see this black anechoic stripe surrounding the heart, and that is inside the hyperechoic pericardial sac, and so this patient has pericardial effusion, right? And the presumption here was that the patient didn't have this prior to being shot, and now has this, and so this is a direct result of the trauma. And so you have to assume that there's a cardiac injury in this patient. So this patient is like, do not pass go, do not collect $200, go straight to the operating room. This needs to be figured out, right? In this particular trauma patient, right? So here's another example. Didn't start. Supposed to start, but basically this image is supposed to show that we had a few minutes kind of while the trauma team was kind of catching up with us, and it basically, as the thing sat, we could watch it grow and grow, and the tamponade physiology kind of develop in front of us. And so the patient ended up going to the OR, did quite well, right? But the patient ultimately was diagnosed with pericardial tamponade secondary to trauma, right? And so this is kind of the thing that we want to talk about, the effusion and then the secondary tamponade. So, the first thing you want to look for when you're assessing the patient, with cardiac ultrasound is, does the patient have an effusion, yes or no, right? Do they have this anechoic fluid? Sometimes in the setting of trauma, echogenic fluid that's surrounding the heart, right? And I guess maybe we need to stop here and pause and just define what is particularly an effusion, right? Because there's been a little bit of there's been a little bit of confusion over the years. Sometimes people will say, oh, there's that teeny little wedge of fluid kind of by the right atrium. Is that an effusion? Well, no, that's not an effusion. An effusion is basically defined, and this is, as I've talked to cardiology, the definition they like, is defined as the presence of fluid, right, in the pericardial space, right? So to be a pericardial effusion, you have to have fluid in the pericardial space. Makes sense. You don't want to have fluid in the belly. That's ascites, right? So pericardial fluid, and it has to be persistent throughout the cardiac cycle, right? And so as the heart squeezes in systole, as it relaxes in diastole, it's going to change size, right? The pericardial sac doesn't necessarily change size per se, but the heart does inside of it. And so you can imagine in systole, right? We all have a little bit of like trace physiologic fluid in a pericardial sac. In systole, when the heart squeezes, that might become accentuated, right? As the heart fills and is relaxed, right, it consumes the space in that pericardial sac, right? It's going to obliterate that fluid in a normal patient, right? If you have a pericardial effusion that is persistent, right, as the heart fills completely and there's still fluid that you can see visible surrounding that heart in the pericardial sac, that is what we call pericardial effusion. Now we can grade that on size, size criteria. So in the gravity dependent areas, is it 0 to 1 centimeter? What's 1 to 2 centimeters? Greater than 2 centimeters is small, medium, and large. But it has to be fluid in the sac, persistent throughout the cardiac cycle, right? And when you have a patient who's hemodynamically unstable, you have to ask yourself, is this causing tamponade physiology? And is this what's causing the hemodynamic instability? Now, the answer might ultimately be no, but you have to then go through that kind of thought process. Is this tamponade, yes or no? And how do we figure that out, right? So tamponade is essentially, from a physiological standpoint, tamponade occurs when the pressure exerted pressure exerted on the heart, right, from the fluid in the pericardial space overcomes the filling pressure in the various chambers of the heart, right? So basically, if we state it differently, when you put fluid inside the pericardial sac, that's occupies space. It's going to create some pressure in the intrapericardial space, right? As you put more and more and more in it, the pericardial sac cannot absorb all of that, and so it's going to create more and more pressure that's going to be transmitted to the actual heart itself, right? You put fluid in any object, and it's going to create a pressure inside that object, right? That's just what happens. At some point, if you put too much fluid in that pericardial sac beyond its ability to distend, right, it's going to have to compress the heart. And when it starts compressing the heart, when that pressure in the pericardial space starts approximating and then exceeding the pressure inside the different chambers of the heart, then those chambers can't fill because it's all pressure related, not gravity fed, but pressure fed, particularly into the right side of the heart. And so if you can't feel the RA and you can't feel the RV, you can't get blood past the right heart into the left heart. If you can't get blood into the left heart, then the left heart doesn't have anything to pump, and then you have hemodynamic collapse, right? And that's what this chart's trying to show is as that right atrial pressure, that golden line increases, right, it's going to cross that right atrial pressure threshold, the right ventricular pressure threshold, and that's when you start seeing a huge decline in your cardiac output and your mean arterial pressure, right? And so that's what happens physiologically in tamponade, right? Now we can start seeing evidence of this sonographically, this phenomena through in three different places in the heart, right? And this is going to be the IVC. This is going to be in the right atrial wall and in the right ventricular wall. And if you want a detailed discussion of that, we have a lecture up on the YouTube channel on the cardiac playlist like we talked about pericardial tamponade and how we really go into the details on that one. But I'll show you a few examples here. So the first thing that you're going to see is IV plethora, right? And so if you cannot get blood through the heart, it's going to back up somewhere, right? I always tell people if you take a river, right, and you put a dam in the river, you're going to get a lake behind it because you're restricting the flow of water in this situation downstream in the river, right, with this obstruction, right? So you get a bigger proximal water body, right? Go to the Hoover Dam, you see Lake Mead behind it, right? And this is what's going to happen. If you can't get stuff past the heart as efficiently, it's going to back up into the IVC. And so one of the key features, one of the key hallmarks of tamponade is IVC plethora. In fact, before I come down dogmatically, I need to probably clear this with cardiology, but I think it'd probably be difficult to make the argument that this is tamponade if you have like a completely flat, empty IVC. You might have to start searching somewhere else. Excuse me. So IVC plethora is kind of the first thing that you're going to look for, right? Secondly, you're going to look at RA, or right atrial systolic collapse. So think about it. The right atrium, while the ventricle is in systole, while the ventricle squeezes, the right atrium is relaxing, right? It's going to be the lowest pressure because it already did its squeeze, right? It squeezed, sent the blood to the RV. The RV now has to squeeze, and the RA has to get ready for the next cycle, right? And so the lowest pressure in the right atrium is during RV systole, right ventricular systole. And so if you have a pressure in the pericardial sac, that's going to start collapsing that right atrial wall in RV systole, right? And you'll see that kind of bowing in. And so if it bows in for greater than 1/3 of the cardiac cycle, that's highly suggestive of pericardial tamponade. And we see that here as we're looking at that RA. You just see that wall just kind of buckling in as the heart is beating, right? And so that's the RA. Looking at the RV, we can move over to the RV here, and you're going to have the same phenomenon, but in diastole, right? Because the lowest pressure in the RV is in the diastolic part of the cardiac cycle. And so as that heart is relaxing, right, you're going to have some bowing in of the RV free wall. Let's get that running again one more time from the pressure that's exerted on it by the fluid in the pericardial space. And so those are the three key findings that you're looking for to help diagnose tamponade in this particular case. So that was number one, the first E, right? Is there an effusion, yes or no? And then is that effusion causing tamponade type physiology? Here's the things you need to look for, right? Case number two, right? We're going to move on to ejection, right? We'll just let the cat out of the bag because I told you it's going to be in order, right? So ejection. So this is a case of a 60-some-odd-year-old male presenting with respiratory failure. I can't talk today. And low sats, right? So the high blood pressure, tachycardic, tachypnic, satting 91%. EMS brings him in on CPAP. You can hear him all the way from the ambulance entrance, just as the patient's coming in, they go into one of our critical rooms, boom, ready to go. Let's see this patient, right? So first thing we can note here is we just do a lung ultrasound or try to do a cardiac ultrasound, right? And you can see most of it's just obscured with just these B lines everywhere, right? And so I think we probably are starting to explain some of the low sats, right? They just got pulmonary edema all over the place, right? But going to the first cardiac view, we start getting something that looks like this, right? So a peristernal long axis view of the heart, we can see just a very, very poor cardiac function, right? You can see just not much of a squeeze at all. It's just kind of, it seems like the LV is more massaging what's ever in the chamber as opposed to just squeezing the thing out, right? And so this is a very low EF, followed by a chest X-ray, shows bilateral pulmonary edema. The diagnosis here is not unclear. I mean, you can make the diagnosis from the doorway when you start hearing their CPAP and see a blood pressure of 200, but it's diagnosis of flash pulmonary edema. But it's a combination of this sympathetic surge that happens while the heart is depressed, and then the cardiac function is depressed, and you start getting backup of fluid into the lungs in the form of pulmonary edema, right? And so I think what this nicely does for us is illustrates kind of the idea of LV function, right? And LV function is an important component to assess when doing the cardiac exam, right? It's kind of like looking at the pump directly. We have to suspend a little bit of disbelief when we talk about our analogy of the pump because, the heart has the left side and the right side. And so maybe we can get a little closer by saying it's a two-stage pump, but they're not like direct in series because you have the lungs in between. So there's some complicated physiology that happens kind of between the right heart and the left heart. But at the end of the day, right, assuming normal RV function, LV function is something that's important to assess, right? It's kind of the main thing that drives blood coming out of the heart into the body, right? And so if you're thinking through, okay, this patient's hemodynamically stable, what's the most proximal thing to the blood vessels that I'm measuring the blood pressure in? Well, it's the LV, right? And so the question I want to know is how well is this LV functioning, right? Is it functioning well? Is it like in hyperdrive, or is the thing just kind of failing, right? Is it just not working? And one of the things that makes LV function challenging, if you talk to the cardiologist doing the comprehensive echo, they have these very elaborate ways of measuring volumes and, spherical discs and, doing systolic, diastolic calculations and figuring out very quantitatively and very mathematically what this LVEF is, right? And one of the hard things about the LV is the orientation of the fibers just go in every which direction, right? There's a longitudinal component, there's a radial component, there's this oblique component. I was reading, kind of thumbing through the paper that this one came from today. There's kind of this folding component, which maybe the paper talks about it. I didn't get into all the weeds, but my understanding that embryologically, the kind of the aorta folds up on itself and forms the LV in the right heart. And so like all this happens. There's a very complicated fiber geometry that happens in the LV. And the net effect of this is that it kind of squeezes in this ringing orientation, right? So if you take a dish rag, like you're doing the wiping down your counter or something like that after dinner, like you wipe it down, you wring out that rag and get all that water out, kind of that twisting, kind of collapsing, compressing motion. That's kind of what the LV is doing, very much unlike what the RV is doing, which is more of just kind of this bellows formation. So quantitatively, it can be very challenging to assess. But the good news is that for our purposes, right, a qualitative assessment of is it functioning normally, is it in hyperdrive, and is it low, like abnormally low or really, really low, is going to be close enough to kind of get us where we need to start while we're waiting for more of a comprehensive, okay, we're at 35% plus or minus 5, as opposed to, what we're doing. So global estimate for LV function in the point of care space works quite nicely. And there's some literature that would back that up, right? So as we start thinking, well, what of our global assessment going to be? We start putting that pattern down of like normal. Okay, that's about 50 to 65% when we kind of quantify that. So we can kind of figure out what's normal look like. Anything above that 65%, we can describe as hyperdynamic, right? And so the example here is, you're shot, you're bleeding out, you don't have a lot of volume, you're just doing everything you can to get every little drop of blood moving forward to be able to utilize its capacity. The heart's just in hyperdrive moving the thing, right? So that's hyperdynamic. And then there's depressed or reduced. I use the word reduced. This paper talks about depressed. Same thing, right? There's synonyms if I switch them up in this lecture. So if it's reduced, if it's depressed, and then I kind of like to do that mildly reduced versus severely reduced. But you could just say it's reduced ejection fraction, right? But generally moderately depressed is somewhere in that 30 to 50 range, and then severely depressed is just you barely have anything moving, less than 30%, right? And so these are the different categories that we're going to use to talk about these patients. And so as we start going to look at slides, we can see I am not entirely sure why it's not. There we go. So we can see in this image, basically you have, very, very poor. This is going to be the severely reduced ejection fraction. So one of the things that we're looking for as we're assessing the LVEF, just kind of that global estimate, I should say not one thing. The two things that we're looking for is there movement of the ventricular wall, right? We'll get that going again. Is there movement of the ventricular wall? Is it squeezing towards the middle of the chamber? Is that circumferential, right? And then is there thickening of that wall? Right. So as you squeeze, that wall is going to thicken, it's going to move in towards the middle. And so if we see not very much movement, right, not very much thickening, that's going to suggest to us that this is going to be a lower depressed ejection fraction, right? Compare that with this one. This is normal, right? So this has good thickening. It's got good movement. In fact, there's almost connection of the two, the inner parts of the wall. Normally you don't see a complete collapse, right? The LV chamber is not completely obliterated as you're, scanning through these patients, right? You'll see some residual capacity in there, but you have good thickening. You got good movement in this patient who's got a normal ejection fraction, right? And then just to show the third example of hyperdynamic, right? We see good thickening, circumferential thickening, good movement, but man, it really gets rid of the rest of that chamber. And so where I kind of like to draw the line is, do we have complete obliteration of that chamber, right? That's probably going to be, hyperdynamic, and it's often associated with tachycardia, as opposed to something that looks more like this, where there may not be complete obliteration of the chamber, right? We can see, most of those beats is still some residual chamber. It looks like it's a very comfortable rate, kind of in the 60s, 70s, and 80s, right? And so, this is kind of how I like to look at it, how I like to assess for this LV function. Now, the one thing to note, we go back here to the low LV function right here. Be very careful. I've seen this come up in QA. tachycardia will mask low LV function, right? Probably clinically, but also sonographically. And so one of the things that I've seen happen is people say, oh, it's normal cardiac function, but it's normal because they see it moving fast, right? When you look at it, you have to look and see how well is the wall moving, how well is the wall thickening despite the rate, right? The rate may be a kind of this mask to try to prevent the heart from completely failing, try to kind of make up that slack for what the heart's not doing in terms of its contractility. So be very, very careful as you're kind of looking and assessing that. Now, if you want to add some quantification to that, the article talks about this thing called EPSS, endpoint septal separation. I'm not going to go into great depth. We have some stuff on the YouTube channel about this and fractional shortening as quantitative ways to assess for LV function. But essentially, you're looking at the mitral valve leaflet tip and how close it gets to the septum, right? And the closer it gets, the more normal it is. The farther away, the more abnormal it is. So when you have low EF, that correlates with a really wide or big EPSS, right? As opposed to something that's going to be normal is going to be kind of getting within 7 millimeters or less of that septum, right? And so there's ways you can mess this thing up if you position it poorly, if you have some mitral stenosis, things like that, can be an arbitrarily low number or high EPSS, low EF. So this, definitely want to be careful with it, but there's quantitative ways that the paper talks about to kind of getting to that EF number as well. So that's ejection. That's number 2. The third one is equality, right? So the case that we're going to associate with this is a 16-year-old patient who comes in status post cardiac arrest, but they got ROSC, which is good because they're 16, right? That'd be a really crummy outcome if they didn't, right? And so we did the cardiac ultrasound. So this is what we have. We have a very normal, going through our protocol, right? We have no effusion, right? We got a pretty normal looking ejection fraction for the patient just being dead a few minutes ago. The septum, we can measure it, but it's not ridiculously, hypertrophied. And, if you slow it down and look at it, if we're getting into more advanced stuff, but there's no SAM physiology because I know all of emergency physicians are like, young person died, is there, hokum? Okay, no, we're gonna take that off the table, right? So that's the parasternal long. Obviously the EPSS is very normal, so it kind of goes along with that normal ejection fraction. But then when we go to apical, right? So this is where the things get interesting. When you look at the LV on the right side of the screen, right? You look at the RV on the left side of the screen, and the question, which one's bigger? In this situation, it's the RV. Now, you got to be careful you're not foreshortening and things like that. But in this situation, the RV is ginormous, right? And so this brings up the question of equality, right? What should the chambers be? In the normal situation, the RV should be smaller than the left ventricle. In fact, the ratio should be somewhere around 0.6 to 1, RV to LV, right? So if the LV is a certain width, the RV should be less than that, right? When you start making the RV and the LV equal in size, right, then we start, adding concern that we have something causing increased right ventricular pressure, right? So either an obstruction in the pulmonary circulation or a failure of the RV itself, right? When the RV fails, it's just going to get big, 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 big. And so we have to start thinking through some of those questions as we assess the equality of these two ventricles. And that's what we're trying to get at here with the equality piece, right? Is there evidence of what we call acute right heart strain when the RV is big? And things that can cause acute right heart strain, PE. Big one. You got to ask that one for sure. More chronic indolent things, pulmonary hypertension, COPD, things like that can be a little bit more of a long-term cause of right-sided heart strain, right? So moving forward here, we went to the parasternal long axis view or parasternal short axis view, and you can see just that ginormous RV, right, compared to the LV. And the other thing that's doing is it's kind of compressing that septum, making it more of a D sign, right? So these are all classic signs that in this patient suggest and showed that the patient had a pulmonary embolus as the cause of their cardiac arrest, right? And so PE is the answer to this question, right? And so that goes through the third E, right? We talked about effusion, we talked about ejection, we talked about equality, right? The RV-LV size ratios. The fourth one we're going to talk about is the exit, right? And so this is looking at the aorta, right? Looking at the thing that comes out of the heart and channels the blood to the rest of the body, right? So this patient is a 40-year-old female, comes in status post cardiac arrest, and they had ROSC. So we're on a roll, 2 for 2, right? And it doesn't necessarily completely reflect reality for all of our cardiac arrests. Wish it did, but we have 2 patients with ROSC, so yay us. This is what happens when you do ultrasound, right? So this patient, okay, fine. They both came in with ROSC before they got here, but Good job, EMS. So this patient, you can see kind of working through our protocol. We have a little bit of fluid there. Well, that's interesting. Certainly not in the gravity-dependent area, but we see a little bit in that corner on the left there, a little bit of corner on the right. It's hard to say, but think it's persistent in throughout diastole, especially I'm looking more of the one kind of towards the apex there, and it makes me concerned that there's a touch of an effusion, okay? But it's certainly not causing, RA collapse, RV collapse. This is not a tamponade type scenario, right? We've already talked about that, so it can't be that anymore, right? So from a effusion standpoint, maybe a little bit. From an ejection standpoint, looks pretty good. We have thickening, we got movement, the rate's pretty good. It looks like it's a pretty comfortable, normal ejection fraction, right? Equality, this one, it looks a little bit big, but honestly, I think it's foreshortened, so it's not going to be essentially a PE issue in this particular patient. So we looked around, we looked at a couple different other views, and here's our parasternal long axis view, right? And one thing that's really interesting, I don't have a pointer here that I can show you, but look at what's just deep to the LA, right? This is a structure, I'm circling, you can't see me circling here, but right in the middle of the screen, there's a rounded structure, right? And this is the descending thoracic aorta. This is the structure that we're all looking for to kind of figure out, proper orientation to the parasternal long axis view. And the thing that jumped out to us is it was ginormous, right? If you look back, you can maybe see that the aortic root is a little bit dilated as well, but this descending thoracic aorta is huge, right? And so it caught our attention. We wanted to keep looking at it. Here, we're going to make it go live. It's just big. If you kind of put it on the scale here, using that reference, it's just under 5 centimeters on that. If you look at the scale on the right-hand side of the screen. So that's big, right? It's supposed to be 3 centimeters or less, right? Here's an aortic or a apical view, just looking at the thing, and it's just ginormous. And if we go long axis, we can see it's elongated. So the concern that we had is, does this patient have, first of all, I mean, it's definitely an aortic aneurysm, right? But do they have an aortic dissection in here as well? And we were having a hard time being able to decipher on ultrasound if they have a dissection. We got all these equivocal images where I was like, is this a dissection flap or is it some form of little artifact in there? But ultimately the patient did get a CTA, and they were found to have a type A dissection extending all the way down through the iliacs, right? And so this was a massive dissection that we first saw on ultrasound, right? And so one of the things you need to think about, right, is you're looking at the aorta, the aortic root, right, is how big is this thing? And so normally is less than 4 centimeters. And if it's greater than 4 centimeters, you have to answer the question, do they have an aneurysm, which is, I guess, by definition, greater than 4 centimeters, or do they have a dissection, right? Is their story consistent with a dissection? Is their exam consistent with a dissection? And should we get further imaging to look for a dissection if we don't already see a dissection flap, right? Now, you can sometimes see dissection flaps on point of care ultrasound, right? It can be this linear, mobile, echogenic structure. If you put Doppler on, you may have differential Doppler flows on either side of the flap, in the lumen and in the false lumen. But it's not always seen best. It's not best seen with a transthoracic echo, right? In fact, if you want to make sure that it's there, you're going to have to either CTA them or get a TEE to look, right? But if you have an enlarged aorta, right, it should start pointing us towards that thought. So here's the aortic arch view, different patient, but this is the aortic arch view. You can see kind of that candy cane appearance. With the cervical vasculature in the near field and kind of the deep, plunge there as it goes down into the chest. And if we put color on that, you can see just this differential in color flow. So you have that aliasing kind of on the left-hand side of the screen and kind of more laminar flow on the right-hand side of the screen there, or of that descending aorta, suggesting the differential color flow in this patient with dissection. And so a few complications you got to worry about. Obviously, is there regurg? Do they dissect into the pericardial space? The conundrum for this patient was, okay, they got a dissection, they got a little bit of fluid in the pericardial space, but there wasn't so much that we would expect them to have died. So we still don't know quite why they died, but it did have some interesting findings that were consistent kind of when you pull the thread on the dissection, right? So these are some of the things you need to worry about. So that's number 4. We talked about effusion, ejection, equality, exit, and the final one is entrance. And we'll talk about it in this final case, the 5th C. We talked about 5 E's, 5 C's, right? This is what the 5th C, 5th case, cardiac case, C. So this is a gentleman, presents short of breath for the last few days. He says, got no chest pain, doc. I'm feeling good, but definitely short of breath. And he was hypotensive, like 86 over 54. Heart rate wasn't horrible, but it was definitely tachypnic, and corrects with oxygen, right? So some labs, elevated BNP, his troponin was mildly elevated. We did CT, it was negative. EKG, no changes from before. So it's like, now what's causing, like, we got a hypotensive patient with a negative CTPE. Here's the chest x-ray. It doesn't look horrible, right? Big, tall COPD-like lungs, but why is he hypotensive? And why does he have a BNP of 2,500? And so it's a perfect opportunity to do a bedside ultrasound, which is exactly what we did, right? So here's a peristernal long axis view going down those E's, right? There's no effusion. The ejection fraction looks pretty good. It doesn't look like there's a lot of LV filling, which is kind of like put a pin there, but could be part of it. He also has pretty normal looking, like I said, pretty normal looking ejection fraction, right? Moving over to the apical view, we have a little bit of an enlarged right ventricle. So we got to the equality. It's a little bit big, right? It's a little bit thickened. If we look a little bit down at the right atrium, that's big as well. So what it's telling me is, okay, the RV is not happy, right? There's something that's not working quite well here, but because it's thickened, because it's big, because the RA is big, this seems to be more of a chronic thing than I don't think he just threw a PE now. And I can have that CT-PE study that I just did that says there's no PE. So, the PE thing, not the case. This is looking more like an RV failure type thing. And if you back up even further, you can look at the IVC and see that it's just big, right? So it measures out at this point at 1.99, which we're looking for something around 2 centimeters or more is abnormally big, right? And so it's right at that upper limits of normal for a large IVC. So this patient, and there's obviously no respiratory changes. Like when you put the M mode on, have him breathe, there's no fluctuation of the size of that IVC. It's just solid big, right? And so this patient, ultimately had RV failure as the cause of their symptoms, right? You got admitted for that. But it brings us to this idea of IVC, right? Inferior vena cava. And the last part of this whole puzzle that we're putting together with the cardiac ultrasound. So the IVC is the termination, right, of the venous system of the heart, right, or of the cardiovascular system. So you have all of the capillaries, venules, right, coalesce into this, inverse arborization and coalesces down into the IVC, right? So if you remember back from, anatomy and physiology, the venous system is also the capacitance system. So it has the ability to expand and hold extra volume. It can contract a little bit and push that volume back into the heart and into the arterial side. So it's a very, very interesting and dynamic part of the cardiovascular system. But that's what it is, right? And so the IVC is this unique thing in that it's the singular tube that brings blood back. Okay, fine, SVC, but IVC, SVC brings blood back to the heart, right? And there are no valves in the right atrium between the RA and the IVC, SVC, right? So it has this unique ability to reflect capacitance of the system, but also has this unique ability to reflect the what's going on kind of in the right side of the heart, right? So it's a complicated part of the cardiovascular physiology, right? And historically, when you looked at the original studies, it was associated with volume status, right? In fact, there are a lot of studies that showed a 1-to-1 relationship with IVC size and volume status. And guess what? When you take a whole bunch of medical students, feed them pizza, measure their IVCs, and then bleed them down or dehydrate them or volume hydrate them or however they did it, there's going to be changes in the IVC, right? But when you take grandma, who's on metoprolol and a whole bunch of other cardiovascular agents, that correlation between volume and size doesn't completely hold up as cleanly as it does when you have a young, healthy, pizza-fed medical student, right? So the way I like to look at IVC is the IVC is a reflection of the right atrial pressure, or for those of you who are in ICU land, it's a reflection of the central venous pressure, or CVP. So IVC, CVP, RAP, in my view, physiologically, they're all kind of synonymous terms. And so whatever caveats you have in terms of how you assess those kind of come into play as you look at all these. And so since the IVC is the termination of the venous system, since it's a capacitance system, as you As you change either the reflection of blood out of the RA through right-sided failure or increase the volume of blood, you're going to see dynamic changes in the size of the IVC, right? And so here's what's considered kind of basically normal. And it's normal because I think this is me a few years ago when I was scanning for slides. But basically it should be somewhere in that 1.5 to 2 centimeter diameter, right? And there should be some variation as you breathe, right? Because, if you think about it, when we take a breath, right, what do? We're flattening out the diaphragm, we're opening up that chest, we're creating temporarily as negative pressure inside the chest, which draws air in from the atmosphere into our lungs. Well, the thing that happens with the air also happens with blood, right? It's kind of it's a cool dual pump, right? It pumps blood into the chest by drawing it in because of the negative intrathoracic pressure, and it draws air in as well. And then when you exhale, the reverse happens, right? You compress all the thoracic size. That air just kind of presses out of the lungs and into the atmosphere, and then you have less filling in the IVC, kind of as that pressure goes back up to essentially zero in the lungs, with this cycle. And so we're going to see some of that pressure is reflected in the dynamic diameter of this IVC. That's pretty normal. However, if you make the thing so big that there's no more capacitance left, you start losing that dynamic nature with the breathing. And also when you intubate someone, you turn them into positive pressure, it kind of changes things. It becomes more of a distensible thing as opposed to a collapsible thing. So anyway, there's a few ways to interpret this, right? So the first one is it normal size? Yes or no. If it's too small, right? If it's a lot less than 1.5 centimeters or so, which is super duper flat, you're having a hard time finding it. Generally speaking, that's a reflection of just there's not enough volume, right? You need a certain amount of volume to keep the thing open, right? And so for whatever reason, you're dehydrated, you're third spacing your volume, whatever. You just don't have enough volume. If you're hemodynamically unstable and you have a flat IVC, you probably are going to benefit from some volume before you start throwing on some pressors, right? And so that's oftentimes what I'll do. I'll scan the IVC if it's, still got some distensibility to it, or collapsibility to it. If it's still, if it's flat, let's give them some volume, see what happens, right? The problem is, that's not the only thing that can happen. Sometimes we see it as too large, right? So if it's greater than 2 centimeters, if it's not moving with respiration, if it's not collapsing when you take a breath, then this is too large. Well, what does this mean? Well, this is where it gets really, really complicated, right? We oftentimes want to assume that it's volume overload, and common things being common, it probably is, right? But you also have to remember that the IVC reflects the heart's ability to do its job, right? So the heart can't do its job, right? If it can't get blood from point A to point B, it's going to back up, and it's going to back up in the IVC, and it's going to make the thing big, right? And so it's also a reflection of cardiac function, right? So is maybe a reflection of RV failure, or maybe it's LV failure that has failed so badly that the RV is now failing, right? So RV, LV failure, that's certainly a possibility. Dysrhythmias can do this, right? If you don't have efficient and coordinated atrial contraction, so I'm thinking about AFib, right? You might have some reflection of that blood back into the IVC because you're just not as efficiently moving it forward into the RV, right? The RV you're not doing is fine, but the RA might be kind of failing in that situation. Valvulopathies, if you have a tricuspid regurg, right, really bad tricuspid regurg, you're more likely to have distended IVC, or some other shunt physiology, or we talked about obstructive physiology with tamponade and things like that. So there's a whole long list of differentials that a big IVC should bring up to you. But when you assess your patient who's hemodynamically unstable, you go look at them, you look at what the IVC is doing, you compare that with the LV, the RV, the effusion, all these things, put the pieces together, and it gives you a better picture than if you just kind of talk to the patient, listen with their stethoscope, and got an EKG and some labs. So anyway, that's your 5 E's, right? If we're going to go back and summarize these a little bit, the 5 E's of echocardiography are effusion, ejection, equality, exit, and entrance. These are the 5 things that we want to go through as we're talking with our patients and discussing kind of what's going on with this patient that's going to help us really understand and put the pieces together with this puzzle as we do our ultrasound, right? And so if we bring this chart back up at the end that we talked about effusion. Is it small, moderate, or large? Does it cause tamponade physiology, right? The ejection fraction, is it normal, hyperdynamic, or really low? How do we look at that? Global assessment, EPSS, right? Equality, is it 1-to-1 ratio, or is it 0.6 to 1 or less, right? Signs of abnormal or normal for the RV size, suggestive of acute right heart strain. Exit, what's our aortic root look like? Is it greater than 4 centimeters or less than 4 centimeters? If it's greater, what should we be worried about? Aortic aneurysm, aortic dissection, and then finally entrance, IVC. What is it doing? Is it like less than a centimeter? Is it like super duper flat, right? Isn't that 1.5 to 2 centimeter range, or is it greater than 2 centimeters with no collapsibility? It's kind of 3 different scenarios here. What are we going to do about that? How are we going to assess it? What does this tell me about the patient? And so these are the 5 different E's. For those of you who want to dig in further on this one, go check out the article. They go into a lot more detail on some of these different things. I found it to be really, really helpful. And with that, we'll wrap things up here. So any questions kind of before we kind of round out the day and conclude things? I guess we'll wrap it up here. I know we've gone a little bit long, and so I appreciate your time, attention, and patience. But today, like we said, we were talking about some cardiac physiology, kind of how we assess that with ultrasound. We do need to probably go back and look a little bit about, the different views and how we're going to, get the views that kind of leads to this physiology section. But we'll save that for a different time. But next time, join us for more cardiac or for more point of care ultrasound. We're going to do is kind of continue on this back to the basic series. We're going to meet again next week. So we kind of got off the every other week cycle with the fall break. So we're going to meet again next week, and then not following week, but then the 3rd week of November. So that's going to be coming up here, for Ultrasound Grand Rounds. But thank you for joining us. Hope you found this helpful. If you missed anything today, if you want to learn about more of other things, go back to that YouTube channel, hit the subscribe button, follow us for more of this great content. Hopefully you enjoy it, and we'll see you next time, same Zoom link, for more Ultrasound Grand Rounds. See you guys. Bye.